Hi there, everyone. My name is Priyarjitani, second year internal medicine resident at Stanford, and we have created a beautiful POCUS series. In the first part of this series, we actually went over the parasternal long axis view. We talked about how to get ejection fraction, Doppler, pericardial effusion, and that's all in the first section. The second aspect of the series was a little bit more focused on the right ventricle, talking about the apical four chamber view, as well as the parasternal short axis view, which you can see here. And then the third video that we just recently wrapped up and should also already be on the channel is all about the sub-xiphoid view, specifically how we can look at the IVC and use that to figure out the type of volume status our patient may have. Today, I'm going to now talk about the fourth section of today, fourth video in this series, which is all going to be about the abdomen and the lung. This is, again, a 30,000 foot overview. Again, I'm going to talk about POCUS of the abdomen and the lung, and I want you to remember that these are not all black and white diagnoses. Usually you take the context of what you find on ultrasound and see how that then correlates with your physical exam. But the beautiful part about ultrasound is I usually never use it in isolation. Someone's having right upper quadrant pain, I can take a look at their abdomen and assess for cholecystitis, pericholecystic stranding, right? You can also assess for stones and things like that. And so I'm going to talk a bit about how to address hypotension specifically and how to use your abdomen ultrasound as well as a lung ultrasound to help you with your overall assessment of hypotension, which is very important. Before I even begin, I also want to continue to re-reference the two big sources for today's video. The first one is the Point-of-Care Ultrasound book, which is fantastic and where a lot of the images are coming from today, as well as the POCUS 101 website. I don't get funded by either of these. I just love the sources, and that's where I'm using them, just so you know. And I heavily encourage you to check out these books and purchase them just so we can support them. Again, not getting funded by them at all. With that being said, how exactly can we use the abdominal ultrasound when someone has hypotension? So let's say someone has hypotension and you're worried about something in the belly. The biggest thing I usually like to do is that one of the biggest causes of hypotension can be bleeding. It can also be if there's something that's often being lost into the peritoneal space. If fluid is accumulating there, you can often have increased intra-abdominal pressure, which then compresses the IVC and then leads to decreased preload and then also leads to hypotension. So one place where I usually like to look is the right upper quadrant. Specifically, if you put the probe, you can see where I'm pointing with my arrow here. You put the probe at the mid-axillary line on the right side of the patient, right here. And when you put that probe at the mid-axillary line, near where you can see the ribs almost connecting to the lateral side of the body, the mid-axillary line, you should be able to see the diaphragm, which is this hyperechoic structure, the liver, which is, you'll start to see has a very unique homogeneous appearance, and then you also see the kidney, which actually looks like a kidney. And one of the most interesting places to look is in this interspace, which is the liver-kidney interspace, which is also known as the hepatorenal recess, aka Morrison's pouch. Why is this so important? Well, this is actually one of the most gravity-dependent areas of our body. And why is that interesting? Well, when things are subject to gravity, they often tend to go there when you're laying supine. And so if you're bleeding into your belly, or if there's a ton of fluid, it usually will accumulate in the Morrison's pouch. You can often use this ultrasound technique to see if there's stuff that's building up here, because that can often tell you if someone's bleeding or if there's increasing fluid in the form of ascites. You can also then use this in the appropriate context. So let's say someone has cirrhosis. More likely than not, this is probably ascites fluid. Let's say someone has concern for bleeding. It could be a hemoperitoneum with blood accumulating here as well. So that's kind of how I like to use this, and this is actually one of the big views that's used in the FAST exam. And so, to summarize, as I said, you can actually check around the liver. You might see this anechoic structure. And again, this is from the textbook, the Sony textbook. And you can see here that you actually do have fluid, but that's anechoic and black. And this is the liver. And so this is just a sign that you do have some intra-abdominal fluid, again, specifically in the Morrison's pouch. It could be hemoperitoneum. It could be free fluid. You have to put this all in the context. It could be chronic fluid. It could have always been there, or it could be new if you have serial exams. Okay? And again, the place where we're looking is this mid-axillary line on the right side because the liver is on the right side. Now, if we're already here, one thing I always like to do is below the diaphragm, you have the liver. But what's above the diaphragm? Well, the diaphragm physically separates the liver from the kidney. So if you actually now just move up a bit above the diaphragm, you should be able to see lung. And again, notice here that we're moving up. Interestingly, they're using a linear transducer. I don't know why. You should be using the phasor array transducer. And if you go here, you can see the diaphragm. And again, you can see that above the diaphragm is going to be lung. And sometimes you can even see effusions, right? Effusions are fluid, and fluid usually shows up as anechoic on ultrasound. And so above the diaphragm, if you see fluid, it's usually an empyema or it could be an effusion. To be able to differentiate between an empyema and an effusion is something that you're not expected to do. But at the very least, you can kind of figure out, oh, okay, so that's an effusion. Below the diaphragm, if you see fluid, that's usually going to be ascites or maybe some blood, depending on the clinical context. And while we're here, let's just go ahead and talk briefly about lung ultrasound. So lung ultrasound can also be done if you take the phase array probe and you just put it on the right side of the chest. I like to use the right side more than the left side of the chest of the patient's chest, primarily because the right side doesn't have the heart. So usually I can evaluate purely the lung. And usually this is the pleural interface, and usually the way lung ultrasound works is the lung ultrasound hits the pleural interface, and usually it doesn't do well with air. So what you're seeing are these A lines that usually will be replicated in any normal person, and the A lines you'll notice are equidistant from one another. And they're also equidistant from the place where you actually hit the ultrasound probe. So the probe to the first pleural line and then the pleural line to the next few A lines should be equivalent from each other. And this is just because, as I said, lung doesn't reflect the ultrasound waves all that well, but the pleural space does. So the pleural space will give you that first line, and then it basically just often replicates itself. And this is actually artifact. This isn't actually true findings in the lungs. You're just seeing that because the lung is filled with air, you're seeing these A lines that are replicated. Most people usually have A lines. The thing that you can often see are B lines, and this is actually not normal. Usually if you have more than 3 B lines in a lung field, those are abnormal. And the reason for that is because B lines often appear when you have interlobular septa of the lung that are thickened due to fluid or scarring. And these are often called lung rockets because notice that the B lines are anechoic. They're not anechoic, they're actually hyperechoic. And you'll notice that they totally destroy the A lines. And so they're called lung rockets, and the reason they're called lung rockets is because they're destroying the A line, and they often come off of the pleural line itself. So B lines can often occur when you have pulmonary edema. It could happen in pneumonia as well. They're very nonspecific, but I will tell you if you see several of them, you can suggest that, hey, maybe there's something else going on here. Specifically, let's say someone has heart failure and you see a ton of B lines, that could be indication of pulmonary edema. So now we can put all of this together. We've kind of gone over the abdominal aspect. We've gone over parasternal long, parasternal short, sub-xiphoid. And now you saw just how important it is and how cool it is that we can look at a lot of these organs pretty quickly at the bedside and use them ultimately to work up hypotension. So if you like this video, please drop a like, comment, share, subscribe. It means the world to me, and I'll see you all in the next video.